Today I'm going to talk about gastroparesis. Gastroparesis is a condition of the stomach where the stomach acts like it's paralyzed. It is emptying too slowly into the small intestine. This is a condition that a lot of times is not tested for. It does require a gastric emptying test to really diagnose it. And in that test, you eat radio-labeled food substance, and then it is timed in terms of how long it takes to get into the stomach. So normally in solid food, we're talking about a half time of about 90 minutes. In other words, the stomach should be half empty at 90 minutes. If you're testing with liquid, it's half empty at 20 minutes is the normal cutoff time. Part of the reason this is not tested for is it's just another test on top of other tests that a lot of times are ordered, and also the treatment for it is often not instituted or thought to be very good, and so oftentimes it's a neglected area of medicine, even in gastroenterology and gastroenterology clinics. So in terms of causes of gastroparesis or gastroparesis, you're talking about a lot of different things. It can be cause unknown, it can be after surgery, it can be in association with infection. I used to see it a lot in gallbladder patients after their gallbladder was removed or before their gallbladder was removed when they were ill, or with pancreatitis. Diabetes commonly is associated with gastroparesis. There are certain medications that can cause it as well. And in particular here, we're talking about narcotics, pain medication, and also there's been all of these weight loss medications. They are known as glucagon-like peptide or GLP-1s. Wegovy, Ozempic, semaglutide, all of these medications can cause gastroparesis, and in some cases there are reports of intestinal obstruction, and these are listed, and then there have been legal issues indicating that the companies didn't provide the information having to do with these complications, and patients who got them were not adequately warned. So there have been legal issues as well. Also with the GLP-1s, there's been some optic neuropathy that has been described and reported, and so this also is adding to legal issues having to do with the drug. In addition to those etiologies or causes for gastroparesis, chronic kidney disease is also listed. Now, it's important to recognize if a patient does have gastroparesis that they may have an obstruction further down from the stomach that is causing it. And it may not be a simple matter of paralysis of the stomach, but more obstruction, and so you can get fooled that way. In fact, I mentioned a case before. This was a young man who had diabetes, kept getting admitted to the hospital being treated for gastroparesis, but in fact on CAT scan had an area that looked suspicious for an obstruction. With the endoscope, we discovered he had a small bowel cancer that was causing the problem. Unfortunately, in the end, he didn't survive, but he had surgery and he did get treatment for this cancer, but ultimately not successful in saving his life. But he was admitted many times for this problem before a diagnosis was made. That's unfortunate. So what is the treatment for gastroparesis? The treatment, I tell patients, is to eat small, frequent meals, and many of them already start doing this because they know they feel better on this. A low residue diet, in other words, you avoid gristly meat, salads, raw vegetables, that type of thing. if possible. And you can get an idea if you're a patient over time what you can tolerate and what you can't tolerate, and you can work with that. In terms of narcotics, if the patient is requiring long-term narcotics, there are reversal agents that are used for the constipation that goes along with narcotics. Relistor was the first one out. That's a trade name. And there are others. Simproic is another one. And so these medications may also help with gastroparesis, although they've not really been well studied, I don't think, as far as that's concerned. But even if the patient's not on narcotics, it helps, I think, to treat constipation, get the large intestine moving as well. And I think that is a helpful maneuver. In terms of medications and other maneuvers and treatments, the medication that is being used in the United States is erythromycin or azithromycin, Z-Max or Z-Pack. This is an antibiotic, and so being an antibiotic, it can cause problems with Clostridium difficile, which can be discussed later under the diarrhea topic. It can cause a lot of other issues, and there's a lot of drug interactions with this particular antibiotic, so have to be careful with that antibiotic in terms of treatment. We don't have a lot of other treatments available for this gastroparesis. Now, the time-honored drug, the drug that's been used for many years, is Reglan, which is metoclopramide. But that drug has some issues and problems, and they are medical legal. Nevertheless, when I was in practice, I used it, and I think if you're very careful with the drug, it can be helpful and useful. Every 3 months, I would see the patient back and reevaluate. The main thing that you want to look for is what's called dyskinesias. So with dyskinesias, and I tell all the patients, if you start having trouble, like you're chewing gum, but you're not chewing gum, and your mouth is moving, your tongue is moving, like that, you need to stop the drug. So I would look for that and tell patients, don't be chewing gum when you come into the office, because that's what I'm looking for. And I give them a handout and I have them sign it. But if you do all that and you watch them carefully and you watch your prescriptions closely, I think you can use Reglan or metoclopramide, and it can be helpful, very helpful, and is used commonly in the hospital. You're not doing long-term treatment in the hospital anyway. Other medications that are available, there's a drug called domperidone that doesn't cause dyskinesias, and that drug is not FDA approved, so you have to be in a study, and I had all of that approved through the FDA to get that drug. It has to be obtained through certain pharmacies, and I handed off all of that paperwork to another gastroenterologist, Dr. Masters, in San Antonio. And I found there really weren't very many people many physicians who had this drug available. A lot of times it is compounded in a compound pharmacy, and they're able to sidestep some of the regulations, but at any given time, the FDA can step in and cause that to be stopped. The drug is available through Canada, and those patients have to be monitored a certain way according to the FDA regulations, and I was doing all that, and had to go through an institutional review board and so forth. But I went through all of that. So it is possible, but difficult to get the drug, and it has some issues as well. But it does not diffuse into the brain, so you do not get dyskinesia. So that was one nice advantage, and it is available in some other countries, such as Canada. That's domperidone. Sounds like a champagne. There is a device, it was Intera device, it was called. gastric stimulator device, and this was a device that you really couldn't show improved gastric emptying, but it did help symptoms. So some patients were given the Entera devices placed surgically. Beyond that, you're talking about placing feeding tubes beyond the stomach because the stomach is not working well, or just be always on a liquid diet, but the feeding tube a lot of times is required and can be helpful in very difficult cases. Another modality that's been researched and looked at is to attack the pylorus, either with Botox, and the pylorus is the muscle at the end of the stomach that may be relaxed with Botox or can be opened up surgically. That's called pyloromyotomy. So those have been looked at, and there have been some positive results, and there have been mixed results, and so that's also a consideration. And so with that, I'm going to end this talk on gastroparesis.